Good afternoon, everyone. We want to start by welcoming you. Thank you for being here. My name is Jamie Cabrera, and I'm executive pandemic now for a few months. We, as an organization, have been working with our partners at the Colorado Department of Public Health and Environment, or CDPHE, and other members of the collaborative to collect information and survey many of our providers across the state to really figure out what we could do to provide support in perinatal care as you're all caring for pregnant postpartum people and infants and their families during this stressful time. So we've compiled some of the hottest topics that we found in that survey and brought to you some speakers this afternoon that will share information about what's happening in our state and what's happening in terms of protocol and care and guidelines for pregnant postpartum people and infants. We felt this was an opportunity to create a space for us to come together, to share information, disseminate these best practices, and really facilitate ongoing learning. So this is the first in a series. We hope to hold these webinars every 3 weeks and drive the topics of discussion based on your input on what you would like to have conversations around and learn more about. Just a few housekeeping items. We will hold questions until each speaker is finished at the end. We will allow you to go to the bottom and you'll see a little icon for Q&A. You can type your question in at any time. We'll be collecting those and then we'll verbally go through those at the end of the presentations. So no fear, you don't have to worry about forgetting your question. You can pop it in there during the presentation and we'll make sure we get to it. We also, if you don't mind, would love it in the chat box at the bottom if you would go ahead and just give us a couple words or terms for your role. We know we have a lot of clinical providers today. We have some advocates. We may even have some pregnant people, parents, and we'd love to hear from you so that we can better gauge the topics and the content of these webinars going forward. We also have a few interactive polling questions throughout the session, so please engage. That will help us learn a little bit more about what you're doing in your facilities and in your environment caring for patients. And if you do need to speak up, we can unmute you, but everybody who has joined the webinar is automatically muted. That will help us keep down background noise while our speakers are presenting. We are recording today's session, so audio, video, chat, and questions will all be documented and will be shared with all participants after and will be made public so that anybody who might have missed the webinar can join in and learn as well. So with that, we're going to go ahead and get started, and I'd like to introduce our first speaker. Sorry, next slide, thank you. I would like to present to you Dr. John Samet. Dr. Samet is a pulmonary physician and epidemiologist and is currently the Dean of the Colorado School of Public Health and a professor in the departments of epidemiology and environmental and occupational health. Dr. Samet received his bachelor's degree in chemistry and physics from Harvard College and a medical degree from the University of Rochester School of Medicine and Dentistry and a master's of science degree in epidemiology from the Harvard School of Public Health. His research has focused on health risks of inhaled pollutants, particles and ozone in outdoor air and indoor pollutants, including secondhand smoke and radon. He has also investigated the occurrence and causes of cancer and respiratory diseases, emphasizing the risks of active and passive smoking. For several decades, he's been involved in global health, focusing on tobacco control, air pollution, and chronic disease prevention. He has served on and chaired a number of committees, including working closely with the US EPA and the FDA. And we are so pleased that he's here today to talk to us a little bit more about epidemiology and modeling of COVID in Colorado. Stage is yours, Dr. Samet.
Okay, great. Thanks, Jamie. And we're going to dash through a lot of material about the modeling that our group is doing. So if I could have the next slide, please. So about 3 months ago, as the pandemic took off in Colorado, we've long had a partnership with CDPHE and began to work on modeling the COVID-19 epidemic in Colorado. And this is our team. We have a lot of talent across our universities, folks from the School of Public Health, Medicine, our Denver and Boulder campuses, and CSU. And go to the next slide. I'll talk about what we do. So we are modeling the epidemic. What that means is we're using mathematical representations of how the infection flows through Coloradans, who it affects, and what happens. Just some really basic ideas. If you think about a population and think about us and the SARS-CoV-2 virus, before this all started, none of us had seen it. So we were all susceptible. And over time, we've had this epidemic rise of infection. Some of us, of course, have recovered. Some of us have not made it. Of course, the pandemic is causing large numbers of deaths. So what we're doing in our model, if we go on to the next slide, is representing all of this mathematically. So our model is the so-called SEIR model. Start on the left, susceptible, exposed to the infection. I, infected. And when we flow this across, some people are symptomatic and infected. And with this virus, one of our challenges is a substantial portion, particularly among younger people, are infected but asymptomatic and are out shedding the virus. For those who are symptomatic and infected, some need to be in the hospital, some need to be in the ICU. We hope that most will recover, but of course, there's substantial mortality with this. So in our model, we're looking at the flow of people from box to box to box and changing key parameters like what happens when we reduce social distancing, wear masks, isolate symptomatic cases, bring in contact tracing. So we're looking at all of these in the mathematical representation. And I think the next slide, if you click one more, just says this. So when we use these models, we look at what happens if we lighten up on social distancing, what happens with increasing mask use, and so on, our epidemiological control measures. So go to the next. We use these models, keep going please. We use these models to look back and say, what happened? How has the epidemic behaved? Have we brought the curve down? And then we look forward using the model to project out what can happen in the future under different scenarios. So next, as we look at, go to the next slide. As we look at the, let's see. So Megan, can you go to the, there we are, okay. So when we look at what has happened, I think everybody knows we've been through safe at home, safer at home. The governor is now talking about protecting our neighbors, a more local and regionally based approach. Over time, there have been many measures. We were more distanced, we were at home, and now we're lightening up. We're watching very carefully to see what happens. And we're also projecting out to the future on this, what could happen. Next, please. So a quick look. Now, the plot on the left is the number of people in hospital. And we're using this for tracking the course of the epidemic. You can see it went up to about 800 plus people in the hospital, and it's come down. Deaths have come down. So this has been good news. The green curve is what we fit. And what we would like to see is that green curve still going down and not heading back up. Associated with all of this, and you may have heard it, is the famous R0 number, the number of new cases generated per infected person. If that's above 1, an epidemic occurs because each person makes more than one sick. If that's below 1, the epidemic is coming down. Curve on the left, hospitalization coming down. Figure on the right, the R0 value, which right now is below 1. And we're watching this very carefully as we take measures to lighten up. So the next slide is now, well, this is where we were a week ago, and let's skip this one, just move on to the next one. So this is the heart of where we think things may go. And we do projections like this week after week. We share them with CDPHE and the governor's office. So these are curves now looking out to the future. The dotted horizontal line, our ICU capacity to take care of patients with COVID-19. Scenarios of social distancing give you a feel. Right now, we think we've roughly reduced our contacts by 65 to 70%. Projecting forward, if we stayed at that, we'd be on the white line. and we'd be well under that threshold. If we go to the red line, go back. If you go to the red line, then things are starting to come towards that dotted line. On the left, all people under 65 and older maintain a high level of social distancing. So the deaths, 90% plus from those who are 60 and older. ICU hospitalizations, 50% below 60, 50% above. So if those who are vulnerable maintain a higher degree of social distancing, they're protecting themselves, left-hand panel, and they're sparing the burden of ICU hospitalizations. And the right, perhaps more realistically, we make the assumption that half of those older adults maintain social distancing at 65%. So moving into the fall, you can see the rise across the summer, focus perhaps on the red line, which may be a realistic scenario as we lighten up measures. You can see that a peak comes, it starts rising across the late summer and fall, and in the left-hand scenario comes close to that mark. So why would we experience another curve like this? It's because about 3% of Coloradans have been infected, and we hope are now immune. The rest of us aren't. So we're sitting there waiting, the virus returns, it'll have at us. Next, please. So just one of our tools is masks. These are some scenarios of having more and more people wear masks. In just one of these future scenarios I showed you, the more we can get people to use masks, the better off we will be. I think it's unfortunate that a public health tool has become politicized. Mask wearing is really a no regrets strategy to follow. And then, yeah, this is a picture I like. This is our governor meeting Vice President Pence, and I don't need to say who has the mask here. Next. And then last, contact tracing. So CDPHE and the local public health agencies are quickly ramping up contact tracing and case isolation. Again, curves projected out to the future, not doing either case isolation nor contact tracing, and then adding one, the other, and then both. And again, another very important public health strategy. And I think that's the last slide. We'll be out of this when we have a vaccine, or when we have enough people infected and immune to return immunity. So thanks, a really quick view of an awful lot of information, and all our reports are posted at the School of Public Health website if you're interested in them. Thanks.
Thanks, Dr. Samet. And we can be sure to include that link for those participating here and when we send resources so that folks can go and take a look at some more of that interesting data. All right, up next, we have Dr. Megan Zemley. Dr. Megan Zemley has been at the University of Colorado Anschutz campus since 2018. She's a member of the Department of Obstetrics and Gynecology and serves as an obstetric hospitalist, colposcopist, and medical director of labor and delivery and postpartum. She trained in Virginia and Texas and was a faculty member at the University of New Mexico for over 15 years. Dr. Zemley is an oral board examiner for the American Board of Obstetrics and Gynecology. Her interests include international healthcare, patient safety, and quality care. And today she's going to talk a little bit more about care of the pregnant person.
Great. Hi. I'm Dr. Zemley, and as mentioned, I am the medical director here at CU Anschutz. I had a few things that I wanted to talk about today. First of all, just objectives. I was asked to talk about the guidelines and protocols we're using here at Anschutz to give folks an idea about that. And I also wanted to mention that I have my email on the last slide, so if anybody has questions or concerns that don't get answered during this webinar, I'm happy to answer them. All of our protocols and guidelines that we are using locally have been made based on guidelines from national organizations like the CDC or the American College of OBGYN or College of Nurse Midwifery. They've been tailored to fit our system. We've also had numerous conversations with infection prevention specialists at the UC system level before implementing protocols or guidelines. There's not at this time, but has been a hospital command center staffed by folks from infection prevention and other services that helped us to coordinate our concerns and questions amongst different services. Next slide. So for patient education, we've really used some basic stuff like the CDC website. The CDC has a really nice area on their website that's very easy to understand about how to protect yourself and how to protect others. And so that's been a really helpful resource. Next slide. Also, CU Anschutz, and I think pretty much every hospital every website that I've looked at in the last couple of months has information on what they are doing for prevention of COVID and to keep people safe in whatever the institution might be. So Anschutz says the same thing, and this is updated quite regularly, and that's another place where we've been sending patients for information about what's going on. Next slide. But I think the thing that really hit all of us when we first entered into this pandemic was the incredibly large number of phone calls we were getting from patients. Totally understandable, that's really scary, but it was quite overwhelming. And so CU Anschutz thankfully opened up a dedicated phone line to answer questions that patients had, both obstetric patients, of course, and then all the other patients. And that was really helpful and timely for us because otherwise clinicians and nurses were really getting buried under phone calls. Next slide. So with regards to prenatal care, things that have changed in prenatal care, one of these is that everybody is getting screening for symptoms. That's true with anybody who comes into the hospital or to the clinic, and I think that's pretty common across all systems. We are providing education for patients and support, also information on decreasing exposures. There is some information I'll show you in a minute on a support group that our Department of Psychiatry began. I was asked when asked to speak at this webinar to make sure that people are aware of algorithms and guidelines that can be used in various places. And so ACOG has a nice algorithm that's free and not something that you need to be a member to get a hold of, and that's the algorithm for caring for pregnant women with confirmed or suspected COVID-19. It's pretty basic, but I think quite helpful. The other thing that we have been doing a lot is telehealth, and I have to say, if I think there's been one good thing that's come out of the pandemic, it's been an increase in our capacity to provide telehealth. We've been doing a fair amount of prenatal care via telehealth, and we can't do everything via telehealth, but if your patient can access and use a blood pressure cuff, you can definitely minimize the number of visits that they are required to have in person. And so we've been doing that, and it's been quite appreciated by patients. One of the last things that I just wanted to mention, and something that ACOG has mentioned, and I think that Dr. Berry might have a little bit more to say about this when he speaks, is that we've noticed significant disparities. I don't know if I should say disparities in care or disparities in the patients who are coming in who are COVID positive in our hospital. And it definitely does seem like under-resourced and women of, under-resourced, I guess, and women of color, definitely more affected. Next slide, please. So, as people have been trying to quarantine more and more, support groups are more and more online, which is great. This is a support group that anybody can join. It is a virtual support group sponsored by the Department of Psychiatry at CU. And I definitely, if people are interested, please don't hesitate to go there or send your patients there for support. Next slide. So I'm just going to talk a little bit about what we've been doing for testing, visitors, and on the unit itself. So the testing that's available at the hospital we're doing the nasal testing on adults. I'll let Dr. Berry talk about the neonates. We have a drive-through test place. It does take 18 to 24 hours or even longer to get your results back. We are also able to do testing inpatient. We have been testing admitted pregnant patients for some time, but CU has recently started testing all admitted patients in the hospital. We are seeing a surprisingly large number of asymptomatic positive women, pregnant women at our institution. Our numbers have been consistently 10%, sometimes up to 15% of the asymptomatic women we check are COVID positive. This is more than we've seen in the rest of the system from folks that I've talked to, and I don't know why that is. We have researchers who are beginning to work on the problem now. And why are we doing the test? Well, we're doing them in order to provide safety for our anesthesiologists if a woman needs to be intubated, and then of course for discussions of how to deal with the baby and potential separation, as well as follow up with the mom, which I'll talk about a little later. Next slide. So the visitor rules, as I'm sure everybody knows, have changed approximately every 20 minutes, and it's been really hard to keep track of what's allowed and what's not allowed. This is the most recent iteration of the guidelines for UC Health. For obstetrics, our patients who are COVID negative are allowed 2 visitors or support persons for the duration of their admission. If they're COVID positive, they're still having a support person, but just 1 person at that time. Doula providers are considered a support person, and so if the patient desires to have her doula present, she is certainly welcome to do so, and we've definitely had people take advantage of that. Next slide. So we have had lots of, sadly, lots of women who are ill with COVID-19 who happen to be pregnant. This became obvious really near the beginning of the pandemic. These folks, provided their primary concern is not obstetric, are managed by our medicine COVID teams, and we see them on a daily basis from the obstetric perspective. The patients are being monitored at least once daily with fetal monitoring, and the medicine team is also notifying us if there are changes in status in the patient, if her respiratory status is getting worse, if she's being put on a ventilator, something along those lines. And at that point, we will monitor again. Delivery mode is per usual indications. I believe it in some of the reports out of China at the beginning of the pandemic, they were doing cesarean sections on all these patients. We are not doing that automatically. For patients who, we have done several C-sections on women who were in the ICU with intubated and had began to have fetal distress for probably lack of oxygenation. Those folks had C-sections, but that was an obstetric indication of category 2 to 3 remote from delivery. Otherwise, the delivery mode is as per usual indications. Next slide. I'm not going to talk much about this. These are the protocols that we are using inpatient for all patients who are admitted with respiratory issues secondary to COVID-19. Pregnant patients, aside from fetal monitoring and then attempts at pumping after delivery, are not being cared for much differently than their non-pregnant other folks. Proning does cause some issues with fetal monitoring as well as with trying to do pumping, but we work around that as well as possible. I did want to mention that something that we have found very useful is that the University of Washington has their protocols for caring for pregnant patients with COVID available online for free. And I know there are some other institutions that have them too. The University of Washington was the first ones we looked at, and we use those a lot when designing our protocols. Next slide. And then I wouldn't expect anybody to read, but I just wanted to mention that there has been some stuff in the news lately about the increase in coagulability in patients who are COVID positive. Pregnant women are already hypercoagulable, and the concern has been that they may be even more so if they are COVID positive. There are no signs for beginning blood thinners of any sort in pregnant women at this time. However, we have begun a protocol where patients are, some blood is taken from patients when they're inpatient, and we're especially looking for labs that are indicative of a worse COVID outcome. And patients who go home are being followed either routinely or intensively by nursing staff with consideration of placing the patient on anticoagulants if some of her labs are elevated and if she has other risk factors. So this is a new thing, and I just wanted to mention it because we've had lots of people asking questions about whether they need to use anticoagulation in these patients. And then lastly, I put my email there in case anybody has any questions that I could possibly help with. And I think that's my last slide, so I'm happy to answer any questions at the end.
Thank you, Dr. Zemla. I apparently wasn't saying your name correctly, so.
Oh, it's okay.
Moving forward, I will make sure I am. I got that. You can call me Jaime if you would like.
No worries.
Next up is Dr. Rachel Wright, neonatologist at Obstetrics Medical Group of Colorado, assistant clinical professor of pediatrics with University of Colorado School of Medicine. And Dr. Wright grew up in Texas before moving to Colorado to complete her pediatric residency and neonatology fellowship at Children's Hospital, Colorado. She is a neonatologist in private practice and covers neonatal ICUs and well baby nurseries in 9 hospitals in the Denver area. She has been part of CPCQC since 2011 and currently is our board chair, which is a position she's held since 2018. And Rachel's been instrumental in leading CPCQC through its transition from an educational council to a true state-based perinatal quality collaborative. So we're fortunate to have her, and we're lucky to have her here today to talk a little bit about her experiences in the hospital she's working in caring for infants.
Thanks, Jamie. I appreciate the kind introduction. As Jamie mentioned, I'm in part of CPCQC now for a while and am interested in neonatal quality improvement research. However, my talk today is mostly about clinical issues related to care of the neonate in light of the recent pandemic. Next slide, please. So a little background, which I'm sure all of you are aware of, but I think it sets the framework nicely to discuss before we go into the CDC guidelines. So it is somewhat reassuring to know, at least in neonates, that COVID-19 is unlikely to be transmitted vertically from mother to baby, except in rare cases. It is unlikely to be transferred in breast milk. Neonatal infection, when present, is most likely from exposure to infectious respiratory droplets, not vertical transmission. And the majority of infants, luckily, with COVID-19 are asymptomatic or have mild disease, but some will be severely affected and require mechanical ventilation or other support. And so having this information does give us, again, some framework to think about how we take care of these pregnant patients and their babies. Next slide, please. I'm briefly going to go over the OB guidelines, not to sort of step on Dr. Zemla's toes, but I think it, again, helps us understand the follow-up neonatal recommendations. And I think it's helpful to talk about what the CDC considers to be a pregnant person with suspected COVID-19. So I think a very important footnote on their webpage that talks about obstetrical care and patient with suspected or confirmed COVID-19 is what that actually means. So for the purpose of obstetric care, a suspected COVID-19 case is someone who has symptoms of COVID-19 or has had a recent high-risk contact, such as a family member at home with COVID-19, and does not yet have a negative test result, either because no test was done or the test is still pending. Some facilities, and there are some in the area, including at university and one of the hospitals that my group covers, may choose to test all patients regardless of symptoms or known exposure as part of a universal testing protocol. Regardless of pending test results, pregnant individuals who are asymptomatic at the time of admission and have no history of high-risk contact should not be considered to be suspected cases. And I thought that was really important to differentiate, because as we move towards universal testing, which again, I think more and more hospitals are moving towards, it's important to know then how to care for these women who have no symptoms and no close contacts, and how we contrast that with women that do. Next slide, please. So in general, the CDC recommends that the hospital should be notified prior to the arrival of a pregnant patient if COVID-19 is suspected or confirmed, so that appropriate physical location, PPE, and personnel may be readied. There has been some change in language in the CDC guidelines over the last month or so in terms of what PPE is necessary. And the current guidelines recommend physical isolation in either a single person room with its own bathroom, if possible with the door closed, or an airborne infection isolation room, which we otherwise might call a negative pressure room if available. Previously, CDC guidelines recommended that a mask, a face mask, was adequate to care for these women when they are not undergoing aerosol generating procedures. But now the guidelines actually state that they should wear an N95 respirator if available, gown, gloves, and eye protection when in the room with known or suspected patient with COVID-19. So that is a little bit of a change over the last few months from the CDC. Patients undergoing aerosol generating procedures should be housed in a negative pressure room if possible, and healthcare personnel should in fact wear N95 or higher level respirator, gown, gloves, and eye protection. So that recommendation is a little more forceful for patients undergoing aerosol generating procedures. Next slide, please. Testing of symptomatic pregnant patients should be prioritized. Testing of asymptomatic pregnant patients is at the discretion of providers and facilities. Some of our hospitals that we cover, which again are 9 hospitals in 2 different hospital systems around the Denver area, are testing all pregnant patients prior to delivery. One of those hospitals, actually one of those hospital systems, has found a asymptomatic positivity rate of about 1%, but that does include all surgical patients and not just pregnant patients that are presenting. I tried to dig down and get some more information on that today and was unable to get the statistics in time for how many pregnant patients we're actually finding are asymptomatic and positive. But overall, for all 2,000 patients or so that were tested at that one hospital, about 1% were positive if they were asymptomatic. The CDC states that isolation should continue to be used in a COVID-19 positive patient until discharged, and may and very well should continue at home to decrease transmission to the neonate. And then overall, the obstetrical patient may be discharged when clinically ready per usual guidelines. Next slide, please. Pregnant patients that are suspected or confirmed to have COVID-19 should be limited to visitors that are considered essential persons. Dr. Zimla spoke a little bit about the visitation policies at university. Those are similar to, I think, the policies around the Denver area. The hospitals that we cover, again, allow between 1 and 2 support persons on L&D, including doulas. That has evolved, again, as mentioned, pretty frequently over the last few months, but does continue to loosen a bit over time. Visitors, the CDC states that visitors to labor and delivery should be screened for symptoms and not allowed to enter if symptoms or fever are present, and visitors should not be allowed to visit public areas and should be instructed on use of masks per facility guidelines, which I think most hospitals are now requiring a face covering of some sort. Next slide, please. I'm going to move on now to neonates and care of the neonates, and then talk a little bit about what our practice has determined to do at the hospitals that we cover. So the CDC states that neonates born to mothers with suspected or confirmed COVID-19 should be considered as having suspected COVID-19. This is despite the likelihood that vertical transmission is really pretty low risk. However, there certainly are case reports of this happening. Testing is recommended for all neonates born to pregnant patients with confirmed or suspected COVID-19. That's recommended via an oropharynx, nasopharynx, or nasal swab sample. I've personally found that the oropharynx sample is the easiest to get in a neonate. It's pretty hard to get those swabs in the nares of a neonate. They're just not big enough. And so oropharynx seems to be the easiest to be most effective at getting. And then the CDC recommends testing at 24 and 48 hours of age. However, if a neonate is going to be discharged prior to 48 hours, they recommend one test somewhere between 24 and 48 hours. Next slide, please. They recommend that neonates should be isolated from other neonates and cared for with recommended PPE. So in the hospitals that my group covers, typically that means that those neonates are not taken to the nursery. They're not taken to sort of any public areas. They're not co-housed with any other neonates. Next, the recommendation that I think has caused a lot of grief among many families as well as providers is that the CDC does recommend temporary separation from mother with suspected or confirmed COVID-19. That separation could include placing a baby in a separate room or placing a baby within mother's room, but at least 6 feet away from the mother. And then if that is performed, the CDC does recommend some sort of physical separation, such as placing the baby in an incubator isolate to provide some, although certainly not complete, protection from droplets, infectious droplets. However, the CDC and the AAP recommendations state that decisions should be made in accordance with mother's wishes. And so in my experience, and I'd be interested in hearing Dr. Berry's experience as well, but I found that about 50% of families decide to separate from their baby in a different room, and about 50% decide to physically separate, but have the baby in the room with them. If the mother chooses not to separate or separation is not feasible based upon the needs of the facility, the risk of transmission may be minimized by maternal use of a face covering and also practicing good hand hygiene. Next slide, please. The next area that I think has been difficult for families as well as providers is the use of breast milk and breastfeeding. The CDC and the AAP both obviously identify that breastfeeding and provision of breast milk is very important for neonates. However, there are concerns of transmission, not through the breast milk itself, but through respiratory droplets during the process of breastfeeding. And so the CDC recommends that mothers with suspected or confirmed COVID-19 should be counseled on methods of decreasing transmission with breastfeeding or providing expressed breast milk, including proper hand hygiene prior to breastfeeding or pumping, and wearing a face covering while breastfeeding or pumping. And then they do state that if possible, expressed breast milk should be fed to the neonate by a healthy caregiver. So the preference is to have the mother use good hand hygiene and facial covering, express breast milk with a pump, and then that milk is given to the neonate by a healthy caregiver. Mothers may consider additional measures to decrease the risk of transmission, such as cleansing the breast prior to feeding or pumping, or cleaning external surfaces and milk collection devices. However, there's really not a whole lot of evidence to support those measures. They seem to make sense, and so I don't think they hurt necessarily, although there's some discussion about the microbiome of maternal skin, and if you cleanse the breast prior to that, how will that affect sort of that transmission and to the infant. But in general, I think those probably make sense. Next slide, please. Neonates may be discharged according to normal clinical criteria, so we're not necessarily keeping these neonates that have a perinatal exposure longer. In fact, I found over the last few months, there are a lot more discharges of vaginal deliveries at 24 hours and C-section deliveries at 48 hours. I think in general, people are trying to get out of the hospital when possible. Test results are not required prior to discharge, but really that transfer of care from inpatient providers to outpatient providers needs to be complete. There needs to be communication of pending or completed results. between the inpatient provider and outpatient provider, so that the outpatient provider knows what, how quickly or how closely they need to follow the neonate. Neonates with suspected or confirmed COVID-19 will require close outpatient follow-up, and then parents and caregivers should follow guidelines for home isolation discontinuation, which I'll speak about in a minute. Next slide, please. Interestingly, and this does make sense if you think about it, but neonates that are breastfed by their mother with confirmed COVID-19 or have other ongoing close contact with someone with confirmed COVID-19, for example, a father, another caregiver within the home, should be considered as having suspected COVID-19 for the duration or of the mother's or close contact's home isolation, and then 14 days excuse me, thereafter. So that makes sense. If you're considering the caregiver or mother infectious, you would want to allow the incubation time to be completed, which is going to be 14 days after the mother or caregiver is essentially cleared from having infectivity with COVID-19. Next slide, please. I just briefly wanted to mention the home isolation discontinuation recommendations. So there are two different strategies. I'm not going to read through them, but two different strategies for symptomatic caregivers in terms of how long the symptomatic caregivers should continue home isolation. You can do symptom-based strategy, which includes, saying how long it's been since the fever has gone away and how long since the symptoms first appeared, or you can use a test-based strategy, which requires 2 negative tests at least 24 hours apart of the caregiver or mother. And so either of those are acceptable strategies in a symptomatic patient to determine when home isolation can be discontinued. Next slide, please. But now that we are testing asymptomatic women or pregnant patients presenting in labor or prior, it's hard to know when to discontinue isolation if we can't use symptomatology. And so the two options for how to treat those women are based on a time-based strategy. So essentially 10 days since the date of their first positive COVID-19 test. If they develop symptoms during that time, you would then revert to the symptom-based or test-based strategy, or you can use the same test-based strategy with these pregnant patients as well, which again requires 2 negative tests greater than 24 hours apart. Next slide, please. So this is another busy slide, but essentially these are the guidelines that we came up with within our practice. These were based on the CDC guidelines, the AAP recommendations, and again, we actually, there was a lot of communication across the city too. So I spoke quite a bit with Dr. Erica Wymore at Children's. I spoke with Dr. Ann Ryan at St. Joe's. And so there was a lot of really nice coordination and communication across the city to ensure that we're really sort of doing things very similarly. So we have 2 sets of guidelines. This first guideline is a recommendation for well newborns born to mothers with confirmed or suspected COVID-19. You can see on the left side, there are discussions about delivery, who should be there, what should happen. In the middle section, there's recommendations on general infant care, bathing, temporary separation, use of PPE. There's recommendations about feeding, so it's sort of a brief discussion about using breast milk. And then on the right side, you can see discussions about monitoring, which really is just routine monitoring. We're not monitoring that baby any differently than any other well baby, unless, of course, they start to develop symptoms, and then discussion about discharge as well. Next slide, please. And then this is our protocol for preterm or sick infants born to mothers with confirmed or suspected COVID-19. So much the same, but these infants essentially are going to be in the NICU. So we at the 9 hospitals, we not only cover neonatal ICUs, but also cover well babies in many of these hospitals. And so we wanted to ensure that we were essentially directing how to take care of either of these patient populations. So this would be care of essentially the NICU baby. On the left, again, essentially the same delivery room recommendations. In the middle, talking about general infant care, bathing if it's appropriate for that gestational age, things, discussion like if you can place the IV poles outside the room so you're not having to go in and out of the room on a frequent basis. We talk about feeding, which is of course a little bit different in a NICU baby. And then on the right side, discussing care in the NICU, what labs we might want to get in a NICU baby, using airborne precautions for aerosol generating procedures, and then also discussed discharge criteria at the bottom, which essentially is the same as a normal NICU baby. Next slide, please. And then this is just a list of references that I used. It's got the AAP, links to the AAP guidelines, links to all the CDC guidelines that were referenced in here, and then also a link to AAP guidelines regarding breastfeeding in addition. And I'm happy to answer any questions at the end. Thank you.
Thank you, Dr. Wright. Next up, we have Dr. James Berry. Dr. Berry has been a neonatologist at the University of Colorado for 20 years and has been serving since 2007 as the medical director of the UC Health NICU. He is the representative for District 8 on the Executive Council for the section of Neonatal Perinatal Medicine of the AAP. He is currently holding active roles in the COVID pandemic, overseeing a group of medical directors at UC Health and their NICUs, and providing physician support for the command center at UC Health Anschutz. He is the Division 8 representative serving as a liaison between the Executive Council of the section of Neonatal Perinatal Medicine and the Division 8 leaders. So he's actively engaged in the work that's happening on the front lines, and here to talk a little bit more about that work.
Hi, thank you. Go ahead and advance the slide. So I won't go over that too much other than that. I don't know if many of you know what District 8 is, but the United States map there, it's all the states and Canadian provinces that are in yellow. So I'm supposed to represent them at the AAP level for the section of neonatal and perinatal medicine. And I really have, I won't go into a lot of specific detail like Dr. Wright and Dr. Z so nicely touched upon in terms of clinical care guidance, but really I wanted to talk a little bit more about more of a global perspective. And I've gotten that because I've been involved really both at the University of Colorado Hospital as the medical director in the NICU and really thinking about things there. But then also I served what's called the physician clinical support role for our command center. And for those of you who don't know what a command center is, it was set up on kind of a military style, and it's meant to be for mass casualties, explosions that occur in a chemical factory, airplane disaster, mass shootings, things like that. It's supposed to be a command center that's set up for very acute events. Our command center was up for 82 days. So I served a role to help physicians within the hospital, mainly adults actually, who were dealing with patients with coronavirus and thinking about how to test them, cohort them, and different things like that, and how to respond from a system level, especially when it comes to PPE and other interventions that are necessary to keep both patients and staff safe. And then as the District 8 liaison, I interface with a lot of leaders in the region of District 8 to see how they're dealing with the coronavirus, answering questions, bringing those forth nationally. And then sitting on the executive council of this section, I was able to interface with leaders from around the country that are involved in developing the approach nationally for our care for the newborn and pregnant mother with coronavirus. So it's really, I come from it with a lot of different angles, and I've learned a lot. And I certainly was not a coronavirus expert going into this, and I'm still probably not an expert, but certainly I've thought a lot about systems approaches to this infection. Next slide. So I wanted to bring up at least a few important resources that I think you all could use. The first is the section of neonatal perinatal medicine developed a national registry, and I'll show that here shortly. But basically, the first registry was set up for pregnant mothers that delivered a baby within 2 weeks of testing positive for coronavirus, and then really trying to figure out some of the early outcomes of the pregnancies and newborns in that patient population. The second is I wanted to put a plug in for a group called NeoClear, which is Neonatal COVID-19 Literature Evaluated and Aggregated in Real-Time Group. And they have really done a nice job of condensing literature that is focused on pregnancy and coronavirus infections. And then the last is just to let you know on the AAP site, there are discussion boards and other links for the coronavirus, many of which Dr. Wright and Dr. Z had spoken about. Next slide. So the registry was really set up by Mark Hudak, who's the president of the section of neonatal perinatal medicine out of the University of Florida. Next slide. And he puts out an update weekly about the aggregated data that's come out from this registry. Once again, it includes data on mother and newborn dyads whose mothers have tested positive for the virus 2 weeks before delivery. Currently, there's 190 centers around the country that are entering data into this registry. Next slide. This is just an example of the output of what that registry looks like that's available. Shows that 97% of the mother-infant dyads that were included in this registry were inborn, and breaks down their race, the maternal status at the time of admission. 69% of mothers that were admitted and ended up delivering were actually asymptomatic, even though they were testing positive for the virus using the RT-PCR testing. About half of them are being delivered by C-section and half are being delivered by a vaginal delivery, which is quite different than what was occurring in China and other countries. Next slide. So when we look at the overall number of patients that are born, so babies, when I say patients, that's who I'm thinking about because that's who I take care of. Of the 767 mothers who tested positive and had babies, 3.9% of the babies in that group have tested positive for the coronavirus. Next slide. And what I wanted to say is that that registry right now has 900 and some patients and dyads in it. I think before we really drill down into important questions about isolation, about testing, in terms of can we use data from the registry to determine a better testing approach, I think we're getting close to having those numbers, and Dr. Hudak and others will start analyzing the data, and I think over the next month may come out with some information that will help guide perinatal care of newborns, both at the time of birth and then also afterwards for testing and or isolation. The other group I wanted you guys to know about was NeoClear. Like I said, it's the Neonatal COVID-19 Literature Evaluated and Aggregated in Real-Time Working Group. It's actually based from a group of neonatologists at the University of Colorado. I've saved the link there. As of this morning, they had 503 citations related to coronavirus that are aggregated on a Google spreadsheet. They also provide a summary of the literature that they've evaluated over the previous 2 weeks and highlight important issues that they've identified those 2 weeks in important studies. Next slide. So this is the group. They look at the topic experts, look at transmission, clinical features, diagnosis and treatment, neonatal perinatal care practices, and consensus statement from governing bodies. Dr. Dietz, Dr. Neumeyer, Dr. Clyde, Dr. Kirkley, Dr. Sherlock, Dr. Bork, Dr. Stremming, Dr. Huen, Dr. Chasen, and Dr. Wang. They've done a phenomenal job, and they've been used as a resource here regionally as well as nationally to understand some of the important literature that's out there. Next slide. So this is what some of their output looks like, just as an example. What's new in diagnosis and treatment? showing JAMA article looking at helpful visualization of coronavirus, how it looks before symptoms occur and afterwards, and how some of the testing may be influenced by that over time. Next slide. So as a summary of all this, I think that there's been a lot of bad things that have come out of this coronavirus, and certainly it's highly contagious. It's been highly disruptive to our society, to our medical care. And the bad is I don't think, even though I wish it were true, and Dr. Samet did a great job of showing what would happen if we maintained isolation, people were wearing masks. I don't think our society is going to be able to maintain isolation, PPE, hand hygiene at levels that we even saw a month ago. And I think we're already starting to see that in Arizona and Florida. So what became kind of an enemy to our society being the infection, I think it's now starting to be viewed more politically, and then also personal liberties are being taken into account. I think there's little in the way of herd immunity currently, so it's going to come back, and Dr. Samet certainly is the expert on that and showed very nicely what things will look like in the fall and the winter. I think a lot of people are getting sick from this. I think many of you probably have either known somebody who's gone in the ICU or even known somebody who's died because of this. I think it's highlighted how fractured our healthcare system is when hospitals, even within a system, are fighting with one another for PPE and coming up with different rules and regulations regarding the approach to patient care, testing, and isolation. And I think certainly the poor, the minorities, the marginalized have really been affected by this, and just shows once again how our healthcare system is not set up appropriately to care for people that are poor and marginalized by society. So next slide. I do think there's actually a lot of good that's come from this. I think there's a much higher sense of community. In our neighborhood, I see people walking around all the time, conversing with one another at a safe distance, and I hadn't seen that before. I think dogs in our society have gotten walked a lot more now over the past few months than ever before. I do think that it's ignited a much stronger urgency for change, and certainly has been even more so with some of the racial issues that have most recently come out. It certainly has highlighted weak areas in our healthcare system, especially PPE testing, our product supply line, how hospitals are working in silos, and inability of hospital systems to work together in a unified way. But I think with highlighting some of those weaknesses, it's also allowed us to maybe identify some issues that we can improve upon and move forward and work together much better. I've seen teamwork where teamwork didn't exist before. So as an example, we have University of Colorado Hospital has, I can't remember the exact number of NICUs, it's somewhere between 7 and 8 NICUs just within the University of Colorado health system. And because of this, we started meeting on a daily basis to discuss some of the issues in our unit, and it's really morphed into a very good working group. And we didn't really have that before. We had tried to do it over the previous 6 months, but the coronavirus really pushed us working together quickly and really working together as a team. I've seen hospitals within healthcare systems start working together much better, rationing resources and really lending expertise in one area when maybe another hospital doesn't have that expertise. I really do think that the use of telemedicine, like Dr. Z has highlighted, should be one of the shining examples of a good thing that could come from this. And certainly seeing it now at the state level and at the national level, a lot of bills that are being worked on, hopefully passed, will continue to squash down some of the obstacles that have been in the way from telemedicine to become really widely accepted and available for practitioners and patients around the country. And for myself, I've had a lot more family dinners with my family than in the previous 4 years combined. So there are some good things that have come out of this. And there's a lot of good teamwork and a lot of resources. And I've seen people work together quite quickly and in an organized manner. So I'm on the executive council for the section of neonatal perinatal medicine. We're now meeting weekly and talking about very appropriate issues that we're being confronted by, whereas just a short 6 months ago when I was sitting on this council, we spent an hour and a half talking about which neonatologist should win the Landmark Award or the Pioneering Award, which is important. But I think to really make an impact and really do things that are important, we had to shift gears and really focus on coronavirus. Now the gears that we're shifting into is how we can help with endemic racism that exists within our healthcare delivery models, and working from there. So thank you, and I'm willing to answer questions as well.
Wonderful. Thank you, Dr. Berry. And a quick time check. I know we're up at the end of our hour here. A lot of you have already put questions in the Q&A box, and some of our speakers have been working that diligently and getting your answers right to you. We will capture all of those. We'll capture all the questions and comments via chat. We will send a recording link to this webinar so you can watch it again. We'll send all the resource links as well and any other documents that might be helpful. We'll have a quick question when you log off if you just answer that. We heard some great things like telemedicine. We heard mental health in some of the question chat boxes. We also heard equity, PPE. So let us know what we can talk about. There's a lot of information and we could spend an hour on each of those. And so we intend to, and we intend to bring experts in the area and your colleagues. If you're on the line and you are a subject matter expert and want to act as a speaker, we welcome that as well. So I know we won't get to everybody's questions. We will share those questions and answers with everybody via that link. If you have something last minute you want to pop into chat or Q&A, I'll hang tight and my team for just a few minutes as well and make sure we get that. And please fill in that feedback when you log out. We are here for you, and hopefully these are good resources and will be valuable based on what you tell us you need. So any quick questions I'm seeing coming over Q&A? All right, it looks like they were all answered. Wonderful. Thank you, everybody. Thank you to our speakers. You're amazing. We appreciate you, and everyone have a great evening and be safe.